So this was a follow-up to a oral presentation that I had at ASH in 2022 that looked at the broader population that was using Acalabrutinib or Ibrutinib in the real-world setting, and it used a healthcare analysis tool, Optum, that included both academic and non-academic patient data. It was mostly a structured data pool, and in 2022 I reported on, with limited follow-up because we had to start the data analysis from the point of Acalabrutinib's approval, which was only in 2019. So we didn't have a very long amount of data to follow up on, but with limited progression events, which we identified as time to next treatment, so patients going on to a different treatment other than the Ibrutinib or Acalabrutinib that they were on, that there was a larger proportion of Acalabrutinib patients that had moved on to a next treatment than Ibrutinib patients, and it was statistically significant. The numbers are small, and so we need, overall, both patient groups were doing remarkably well, and the overwhelming majority had not required a next treatment, but it was an interesting observation. Of course, prospective data is what is most valuable when we're making treatment decisions for our patients. And we have to still, of course, keep in mind the Elevate relapse refractory study, which was the prospective comparison in the relapse setting of these two agents in a high-risk patient groups. But we probably will not get a frontline comparison, so we used the real-world data to take a look and see how patients were doing. At this meeting, we're presenting data specifically on the high-risk patient subgroups, those that were identified as having chromosome 17 aberrations, and the difference was still there in terms of there was a higher proportion of Acalabrutinib patients that had moved on to a next line of therapy. So I'm interested in continuing to follow this patient group over time to get more information and more data points and see if these trends hold.